Good morning, ladies and gentlemen. Thank y'all for coming out. As y'all know, I've been working on my methodology class, and this is the last PowerPoint presentation, or last lecture that I'm supposed to do for it. It's supposed to be 45 minutes or more. I think yesterday we went through it in about an hour. And the subject we picked to work with today is understanding basic lab values. Us as EMS providers working in the field, we don't get to see and deal with a lot of lab values, but the paramedics that work in the ER do. They get to see and understand them more than we do. So just having a basic understanding of them can help us understand the disease processes that go along and cause these lab values to go up. It also helps us understand maybe why these people are being transported from hospital to hospital, for tertiary care, for a higher level of care. So in doing that, I've done a lot of research online, found a couple of papers, and worked the main body of my lecture from those papers. But I also went in and I called Ms. Haynes in the lab, and I got her to send me the reference ranges that Granville uses. So instead of using the standards that they had in the paperwork that I went over to start mine, I used all of the standards that we have here for Granville. That way, what you see as far as lab value normals here is going to be matching what Granville uses and has. And before I done that, I actually talked to Dr. True. I spent probably 20 or 30 minutes with Dr. True, told him that I was doing a PowerPoint on understanding lab values and stuff like that. And me and him sat down, and he explained to me kind of what process they use for choosing lab values for each person that comes in, depending on what they come in and their complaint was. So say we bring in somebody with a GI bleed. Dr. True says that normally when they come in with a GI bleed, he himself is going to get them to do a CBC, which is a comprehensive complete blood count. They're going to do a type and cross in case the person needs blood. They're going to do a PT, a PTT, and an INR, which is your coagulation ratios and stuff like that to see how they're clotting. And then they're going to do a comprehensive metabolic panel for GI bleeds. And he says, well, if you bring in somebody with a seizure, then they're going to go through and they're going to do a comprehensive metabolic panel. They're going to do a lipase. He's going to check their MAG. He's going to do a urinalysis on them, more than likely. Say we bring in somebody with belly pain, a CBC, which is a blood count, a metabolic panel, a complete one, CMP, a lipase. He may do a lactate, and then he says, depending on the person and what he feels, whether it is belly pain, he may even ask for a troponin level on them and an EKG. For septic patients, he's going to do a blood culture, a lactate. He may actually pull the influenza test on them just to see if that may be the cause of it. And he said then he'll add on whatever he thinks he needs to add on. For somebody who comes in with DKA, he'll do a blood count again, and then he'll do, instead of a comprehensive metabolic panel, he's going to do just a basic metabolic panel. Then he's going to do a venous gas, a UA, and then he's going to do a BH, beta hydroxy. And then for just general sickness, no other complaints, a CBC, a CMP, a lipase, a troponin, he'd do a urinalysis, a EKG, stuff like that. Pediatrics, he said a lot of those get strep test, a urinalysis, flu. He said, and depending on what other signs and symptoms, then he goes into the blood counts and the metabolic panels, lipase and stuff like that. And then for heart failure, heart failure's got a specific one called a BNP. It lets you know. So, and then it, of course, chest X-rays. So in doing that, that's where I kind of started working on my PowerPoint from. Of course, from him, the Granville sheets, and then the others. So our goal today is going to be just to provide you with the knowledge and recognizing changes in common chemistry and complete blood count lab values. The objective is to identify normal chemistry values. I'm going to show you all the normals, define what the normal ranges are, and then define the causes and complications of abnormal lab values. And then we're going to talk about the treatments that may be associated with these normal values. The deal is with the treatments, we don't really treat the abnormal lab values, we treat the underlying cause that created the abnormal lab values. So it's not a specific treatment for most of these lab values. Now yes, some of them can be directly treated, and I'll explain some of those. But these are, like I said, the lab values that Granville regularly uses, and the abbreviations that we have up here: complete blood count, CBC, CMP, comprehensive metabolic panel, your BMPs, basic, and the prothrombin times, the partial thromboplastin times, the international normalized ratios. That's how long it takes for certain parts or certain times for your blood to clot. A lot of people who's on the warfarin, what's the new clotting medication that they're using instead of warfarin now? Eliquis, yeah, stuff like that. Yeah, Pradaxa, that's one too, yeah. So the electrolytes we're going to go over is the ones that pretty much go into a basic metabolic panel and a comprehensive metabolic panel. And they're the sodium, potassium, chloride, magnesium, calcium, and phosphorus. A lot of times the phosphorus is left out for both of them, as far as Granville is using, but these are the ones that we're going to go over. Okay. Sodium, normal values are 136 to 145 millimoles per liter. Millimoles per liter, or millimoles compared to a milliliter, is, I think, 6 zeros compared to none. So I mean, it's a very minute. The major component in sodium is extracellular fluid. It helps in regulating the acid-base balance, tissue osmolality, and enzyme activity. It is necessary for the retention of body water and maintaining our osmotic pressure. Potassium. The normal values 3.5 to 5.1 millimoles per liter. The major component is it's an intracellular fluid. It helps in the enzyme activity, regulation of tissue osmolality also, and then glycogen use. It is necessary for cardiac and nervous system functions. Your potassium is directly related to your heart. If your potassium gets off, it's going to cause some issues with your heart potentially, and more than likely. By regulating the muscles and nerves is the system functions. It regulates your muscles and your nerve excitability. Chloride. Normal values of 98 to 107 millimoles per liter. Also part of your extracellular fluid. It again helps in tissue and cell osmolality. It passively follows sodium and water in your system. It is essential for potassium retention. So if your chloride is low, chances are your potassium is going to be low. Transportation of your CO2, carbon dioxide, and the formation of hydrochloric acid. It's usually provided, say if we had to give chloride to somebody from sodium chloride or potassium chloride. Magnesium. Its normal value is 1.8 to 2.4. Approximately 50% of that is in your bones. The other 45% is in your ICF, and the last 5% is in your ECF, your intercellular and your extracellular. Okay, and it affects enzyme activity, cardiac, and neuromuscular function. And if it's low, your calcium and or potassium is probably low also, because it is directly related to those. Calcium, the normal values for those are 8.4 to 10.6 milligrams per deciliter. majority of this is found in your bones. It's also part of your extracellular fluid, and is necessary for blood coagulation, endocrine function, neuromuscular function like muscle contractions, nerve excitability. It can be altered by vitamin D, thyroid and parathyroid hormones. So if you're taking a lot of vitamin D or getting it, it can mess with your calcium. And then of course the thyroid hormones in your body and extra medication for thyroid problems can alter your calcium. Phosphorus, also found in the intracellular fluid. The normal values for it is 2.6 to 4.7 milligrams per deciliter. It plays a part in the formation of your bones, your teeth, and your neuromuscular function. It helps the body metabolize nutrients. It helps form and store energy like ATP. It is directly related to calcium. If one of them is abnormal, the other one should be too. Electrolyte imbalances. So we're going to pretty much go over each one of the electrolytes that I've done. These are the high and low names: hypernatremia, hyponatremia, hyperkalemia, hypokalemia, hypermagnesia, hypomagnesia. So we're going to go over each one of those now, the highs and lows for it. Okay? Hypernatremia. Causes of dehydration, not drinking enough water, taking in too much sodium. Used to be years ago, sports athletes, football players would take sodium pills, salt pills, to help them retain water and stuff like that. You don't see it as much anymore. Diuretics that increase urine output, vomiting and diarrhea, impaired renal function, CHF and Cushing syndrome are all causes of hypernatremia. So signs and symptoms for us in the field, which relate to a lot of stuff, but you can think in the back of your mind now, if you see these, they could be a possible electrolyte imbalance. Anorexia, nausea, vomiting, dry tongue and mucous membranes, tachycardia, hypertension, altered LOC, tremors and muscle twitching, and then they could possibly be febrile. Treatments, like I said earlier, it's focusing on the underlying causes. What are we going to do, and what is the cause of the reason it's high? And in doing this, that will more than often fix the problem. That's what they're going to do in the emergency room. If they see abnormal lab values, they're going to look for the reason why they're abnormal and try to fix that, which will help rebalance the electrolytes. Hyponatremia, prolonged use of D5W, impaired renal function, Addison's disease, burns, fever, metabolic alkalosis, overhydration, drinking too much water, and diuretics, on top of a low sodium intake to start with. People who have some heart failure issues and stuff like that are told to limit their sodium intake and drink lots of water and stuff like that, or have fluid pills, could very easily get hyponatremia. Signs and symptoms of this, again, pretty much the same signs and symptoms of it being too high. Diarrhea, nausea, vomiting, tachycardia, their blood pressure will be low, they're going to have headaches and lethargy, confusion, muscle weakness, pallor, dry skin and mucous membranes, and then they're going to have a dilute urine. Treatments, again, pretty much the same way we were before, focusing on the underlying causes, and doing this more often than not will resolve the problem. So we need to look for what's causing it and fix it. Okay, hyperkalemia causes taking potassium supplements. For whatever reason, somebody thinks their potassium is low or something like that, they start taking extra potassium, could elevate it. Metabolic acidosis, renal failure, ACE inhibitors and beta blockers can increase your potassium. Trauma, bruising and bleeding, and Addison diseases are all causes of hyperkalemia. Signs and symptoms of that. Here's where you come into your EKG changes. They're going to be tachycardic, they're going to have wide QRSs, they're going to have peak T waves. When we, a little bit later on, when Justin does his EKG stuff, you know, it'll show you some of the stuff that goes along with having high potassium, and we'll be able to show it to you in EKGs. Lengthening of the PR intervals was one of the main things that happened with high potassium, and difficulty identifying the P waves, and also B-fib can come from hyperkalemia. They're going to have decreased urine output, lethargy, and then decreased muscle tones, and sometimes severe cramps. A lot of times, cramps is what leads people to think that they're having hyperkalemia. Focus on the underlying causes. If it is acidosis, then that must be corrected. All right, here's one of the specific things we can do for it. We can give folks K-Exalate. What does K-Exalate do? Doesn't it bind with it and draw it out of your system? Is that what it's meant to do?
Yes, it absorbs the potassium.
Yeah, it binds. It binds the potassium. Calcium is used to decrease the antagonistic effects of the excess potassium on the myocardium. So adding calcium can help control the potassium's ability to excite the cardiac function. And then the insulin and glucose drips enhance the cellular uptake of the potassium, forcing it back into the cells. Forcing it back into the cells also will help with it doing the excitability to the myocardium.
When the potassium encapsulate mix, when it absorbs it, it goes to the urine, goes to the kidneys to excrete it, so people will start urinating orange. So that's one of the signs that it's working.
Cool. Thank you. Appreciate that. Hypokalemia causes of malnutrition and anorexia, decreased potassium through vomiting, diarrhea, gastric suction. A lot of these people that have excess fluid buildup in their stomachs and stuff like that have to be suctioned on a constant basis to decrease the fluid buildup, can also have low calcium. Alcoholism is a direct cause of hypokalemia. Diuretics, again, acute renal failure. Steroids and stress, along with medications like insulin and epinephrine, can cause hypokalemia, metabolic alkalosis, and then Cushing's syndrome. Okay? The signs and symptoms of your potassium being low, EKG changes. This time it's going to be dysrhythmias. Then it's going to shorten your ST segment, flatten or even invert your T waves. And then you'll start developing what they call a U wave on your EKGs. Some other signs and symptoms: anorexia, vomiting and diarrhea, intestinal ileus or gastric dilation, polyuria, malaise, drowsiness, altered LOC, and then muscle weakness can go along with it. Treatments, again, focus on the underlying causes. Any acid-base imbalances need to be corrected. Use of potassium-sparing diuretics, can help keep it from decreasing anymore. Giving supplementation of calcium, potassium slowly will help, and then identifying any other electrolyte imbalances, because remember, potassium is directly related.
The most common one used for potassium sparing is called spironolactone.
Spironolactone.
By the way, y'all know what to look for when you see patients.
That's on spironolactone. Okay. All right. Hypermagnesium, high magnesium, causes taking too much magnesium. A lot of your antacids have that magnesium. Some of them have aluminum in them. Your antacids. Renal insufficiency is a cause. Renal failure, Addison's disease, severe dehydration, and then ketoacidosis. Have you noticed anything about the causes for most of these electrolyte imbalances? What's one of the common things that's kind of showed up in every one of them that we've seen thus far?
Renal or
the renal function. Renal failure, renal insufficiency, just about every one of them has got something directly correlated as a cause for high-end oil load, is that your kidneys are not doing what they're supposed to. Okay? Signs and symptoms of this is going to be weakness and drowsiness, lethargy. It can develop into paralysis, low blood pressure. Magnesium causes third-degree heart blocks. EKG changes, widening in the QRS, prolonged QT intervals. They're going to be red, they're going to be flushing, and then, of course, respiratory depression. Treatment focuses on the underlying causes. You can use IV calcium and sodium. They can decrease the serum magnesium levels. If IV calcium is an antagonist, it can decrease the symptoms of what you're having, and if it's in renal failure, usually dialysis is needed to correct the problem. For hypomagnesia, which is low, malnutrition could be one of the causes. Malabsorption, your body not being able to absorb it. Alcoholism, increased CA2 intake, chronic diarrhea, ketoacidosis, acute renal failure, acute MI, hypomagnesia, having an MI, hypokalemic or hyperkalemia, both can decrease your magnesium, metabolic acidosis, and aminoglycosides like digoxin. Big word for the use of digoxin, but it's called aminoglycosides. Signs and symptoms: hyperirritability. They're going to have tremors. They're going to have spasticity, which means they just spastic. They'll be sitting around fine and then just get to twitching. It's not as regular as somebody shaking, having tremors. It's just, they kind of jerky, like restless leg style stuff. Hypertension, dysrhythmias that can go along with hypomagnesia, DVCs, VTAC, and VFib can also all be directly related to having low magnesium. And then your EKG changes are going to show up as flat or inverted T's and depressed ST. Treatment, focusing on the underlying causes, and then of course magnesium replacement if it comes to that. Hyperkalemia, high calcium causes taking too much calcium supplements. There again, renal impairment, something wrong with your kidneys, not being able to get rid of this stuff like it's supposed to. Thiazidide diuretics. Bone fractures or prolonged immobility can increase calcium in your blood. Some kind of malignancy, something malignant, cancers and stuff like that. Hypoparathyroidism can cause it. Excess use of steroids and hypophosphatemia can also cause it. Signs and symptoms, again, hypercalcium, too much calcium, directly related to the myocardium in your heart. It's going to cause EKG changes. It diminishes your ST segments, shortening of the QT, and can also create third-degree heart blocks. Pathological fractures. If you stay too high, you can cause your body to have fractures. Decreased muscle tone. People show signs of depression. And then flank and or kidney stone. Flank pain and kidney stones can go along with it. Calcium builds up, your body puts the calcium into your kidneys form stones with it. The calcium. Focusing on the underlying causes again, normal saline can help get it out. Loop diuretics can help get your body to relieve. Calcitonins and then corticosteroids can all help. in the treatment of it. Hypocalcemia, low. Renal failure, a low albumin. Chronic diarrhea can be a cause. Hypoparathyroid, hyperphosphatemia again, hyper or hypomagnesia. There we go with the phosphorus and magnesium. One's directly correlated to the other. And then alkalosis. Signs and symptoms of it being low: abnormal blood clotting, tetanus, muscle twitching or tremors, muscle cramps, numbness and tingling, irritability and anxiety. Here again, low calcium directly related to your EKG, your heart, changes on prolonged QT, and lengthening of your ST signals. If it's long term, then you can have and start developing fractures. Hypocalcemia, long term, a lot of the people who have the brittle bone disease, a lot of times are low calcium producing. Treatment, focusing on underlying causes again, and then your calcium supplements for replacement therapy. Hyperphosphatemia, high phosphorus. Causes: taking too much phosphorus, hypoparathyroidism, renal insufficiency, chemotherapy, metabolic acidosis, respiratory acidosis, and laxative overdose. We got to talking about this yesterday. Who would you think normally would do or have issue with laxative overdose?
There's little people who are on bulimia.
Bulimia? Models.
Anybody that's vain.
Vain, yeah. Well, there's one group of people that you really don't think about, and that's the bodybuilders.
Bodybuilders, definitely bodybuilders.
These guys will eat, and instead try to keep from gaining the weight from all the food they eat. They will just follow it up with a bunch of laxative, flush fluid through the system. Especially if these guys are out for shows and stuff like that. It's a big way for them to feel like they're full and then get rid of that excess weight pretty quickly is by doing the laxative thing. And if they do it to an extent, they could overdose on it.
Really bad.
Treatments, focusing on underlying causes. Insulin and glucose can lower the serum levels, phosphorus levels. They can lower it by shifting phosphorus from the extracellular fluid into the cells. Jump one. Hypo, low phosphorus. Ketoacidosis. Burns, metabolic alkalosis, respiratory alkalosis. Some of your causes: diuretics, antacid-containing aluminum. There's the aluminum. Malnutrition and anemia, alcoholism, vomiting, and diarrhea. Have you noticed something else about most all of these electrolyte issues? Alcoholism and nausea, vomiting, and diarrhea pretty much affects it all. So if we go out to these folks that's been sick, having nausea, vomiting, diarrhea for 3 or 4 or 5 days. Where? Yep. It can mess up with all their electrolytes. If it goes on long enough, then you get into the issues of messing with their hearts and everything else. Signs and symptoms of having a low phosphorus in your system: muscle weakness, tremors, bone pains, hyporeflexia, seizures, tissue hypoxia, a weak pulse or hyperventilation, anorexia and dysphagia, and then risk of bleeding and infections go along with having low phosphorus. Treatments, of course, focusing on underlying causes, trying to figure out what caused it to be low to start with, and then replacement of phosphorus for sodium phosphate or potassium phosphate. Glucose. One of the tests that we actually do and can read and see in our trucks. Pretty much the only one that we get direct correlation to lab values. The normal ranges for a non-fasting adult or child is 60 to 200 milligrams per deciliter. That's pretty much non-fasting. If you get to somebody and they got a blood sugar of 208, 25, 30 minutes ago, that's not above normal. Usually the sugar spikes within 30 minutes to an hour after you eat and will gradually drop down back into what we consider the 60 to 120 normal range after that. It's a monosaccharide or a simple sugar. It is a product of cellulose, starch, and glycogen. Free glucose occurs in the blood and is our primary source of energy. It causes us to want to get up, want to move, and the body uses it for all of its processes. And the excess that we have in our body is stored as glycogen either in your liver or in your muscle tissue. That's what glucagon does. Glucagon, when you give it, causes your body to release the excess that it has in the system and helps raise it, but it takes a lot longer than D50 or glucose and stuff like that. Hyperglycemia. This is going to be greater than 200 milligrams per deciliter in a non-fasting patient, or greater than 100 milligrams per deciliter in a fasting patient. So if you fasted or not eaten or drank anything that would cause the sugar to go up in 12 hours or so and it's reading above 100, then a lot of times they will say that you have the potential to be a diabetic. Causes for these abnormal readings are going to be, of course, diabetes, osmolar neuroketonic syndrome. I looked it up, couldn't find a definition that made a lot of sense to me, so I didn't even bother putting it in here. Syndrome, because it was a humongous. It was a definition that it didn't make sense to me.
It's blood sugars above 600. The ones that we get that the monitors don't register, those people are characterized as non-ketotic syndrome. They have high ketones, and their treatment of choice is insulin and giving them diuretics to get all that and make the kidneys function.
Well, what I was reading in it is that this is like a long-term thing. A lot of these folks have to be on insulin drips, not for a matter of hours, but for a matter of days or weeks. Is that
true?
And
yeah, we have one in Forest District that we transport every time we get there. I transported him one day, I think it was you, and he had a blood glucose of 1200 when they did it at the hospital. It was rather sweet.
Increased epinephrine in your system can cause hyperglycemia. And it's from extreme stress, illnesses, trauma, or surgery. Excess growth hormones or secretions, over-administration of glucose, taking too much glucose, pregnancy, gestational diabetes. Getting pregnant can also raise your sugar levels, and then medications such as steroids. Steroids directly relate to hyperglycemia. Anytime my little girl gets sick or she gets put on steroids, we have to be real particular about watching her sugar. She ends up having to get extra insulin every day on a regular basis. She's been sick and put on steroids twice, and her sugar's averaged in the 250s and 300s the whole time she was on the steroids. There wasn't a whole lot we could do to keep it under that. Signs and symptoms. Polydysphagia, increased thirst. When Erin first got diagnosed, that's what clued me in to her having the issue. It was a Sunday morning. She woke up. First thing she wanted to do was something to drink. Daddy, I'm thirsty. Well, it's not dawning on me the first time she said it. We'll give her a glass of apple juice. I was adding insult to injury, not knowing. So after about the third glass of apple juice before she ate breakfast, you know, and she was just consuming fluid all morning. Ate her breakfast, we got dressed, went to church. Every time she passed the water fountain, she had to stop. She drank enough water that morning at church to make herself sick. Not because she wanted to get sick, she just drank and drank and drank till she threw up nothing but pure water. So, me and Katie, still, me being a paramedic for 10 years, it did not dawn on me that her sugar may be high. I got home and it was constant. I'm thirsty. And after about 2 more hours of I'm thirsty, my mind finally settled in to, okay, something ain't right. What causes this? And then it thought, okay, her sugar's high. So, of course, it took me and Kate wrestling with her for about 30 minutes to check her sugar, because it was a fight to just poke her finger and it read high. About 2 hours after that, we were in the emergency room. 6 hours after that, she was on a critical care transport truck going to Wake Forest Baptist Medical Center, and we spent about 4 days in the hospital with her. So, a lot of times, if it's your direct family, sometimes your mind just won't correlate what you know in the field for somebody else may not work for you with your own family. Polyuria. Peeing too much. Of course, dehydration can make it go up. Irritability is part of it. The signs and symptoms, headaches. She has developed headaches since she's had her diabetes, and that's pretty much our sign that her sugar's too high. Right straight off the bat. If she wakes up or complains of a headache anytime during the day, first thing we say, check sugar. Check sugar. And usually, if she's complaining of a headache, her sugar's around 250, going on toward that 300 level. And trust me, once it gets up that high, irritability is a big thing. I mean, she just turns into a booger. I mean, just hard-headed, don't want to listen, grumpy.
That's me every day.
Huh? That's you every day? Have you checked your sugar lately? All right. Once it gets on up past that 300-400 mark, into the 600, 700, on up into the close to 1,000s, confusion is going to set in on these people. And then past that confusion, your LOC is going to go down. And when it gets up and stays up really high for a long period of time, I'm talking from what I was reading, 800 and above for an extended period of time, it can directly interfere with the vision in your eyes. It can cause you to go blind. And it's a permanent. Once whatever it does to your eyes is done, that's it. There's no returning, even if you get your sugar back down. Once the damage is done to your eyes, it's done. A lot of people over time with diabetes, with uncontrolled diabetes, over years and years of having even slightly high elevations in the 2s and 300s can affect your vision to run you blind over a matter of years. Treatment, increased fluid intake, is pretty much what we do for them. Start an IV and start flushing them with fluid. Try to get as much of it out of the system as we can. And then, of course, insulin administration. What we can do when we get to these people that have these sugars of 400, 500, and 600, one of the first questions we want to ask is, have you taken the insulin today? Well, no, I hadn't taken it. Have you got any here at the house? Well, yeah, I got some insulin. Well, how about let's go ahead and take some. You can direct them to take what they are supposed to take on a sliding scale or something like that to help start correcting the issue, and then get them transported to the hospital where it can be rechecked, evaluated, and monitored. Hypoglycemia. This is anything less than 60 milligrams per deciliter in a non-fasting patient. Okay, causes of it, imbalance between your energy consumption and use. So you get up, you want to run 2 or 3 miles first thing in the morning, you don't bother to eat breakfast good. After about 1.5 miles into your run, you're feeling weak, confused, really tired, your body's burning up more than you have stored and available in your system. Malnutrition can also cause it. Taking too much insulin, of course. Liver disease like hepatitis, cirrhosis, and liver cancer can all cause your sugars to stay low and be low. Overproduction of insulin in your system and insulin secreting tumors. There are actually tumors that can develop in the body that will secrete insulin, separate from the pancreas that helps secrete it and regulate it. Medications like beta blockers, sulfonylureas, and hypoglycemic agents, oral hypoglycemic agents can also cause hypoglycemia. Signs and symptoms, of course, we all know. We get in there, these folks are altered, potentially combative, going to be confused. Some of them can have tremors or jitters, shaking. A lot of them complain of being hungry. Color's not good, pallor, and then diaphoresis, sweating. Those are all signs that we've seen in the field ourselves that go along with this. Treatments: providing glucose and carbohydrates through food, oral glucose, IV dextrose, and glucagon. So to give the oral glucose, I asked them yesterday, what's their standards for giving oral glucose? You know, what do they have to be?
Alert, a sugar above 60.
Able to swallow. A lot of times it needs to be above 60. When do we start treating low blood sugars in our patients?
Less than 40.
Our protocols have one specific number, 69. 70 and above, technically we don't treat, but 69 is where we start our treatments at. So, but 60 usually is our cutoff as far as, you know, going from oral glucose to D50, because once it gets below 60, a lot of times their mental capacity is not there, and if it's not there, chances are the ability to swallow is diminishing also. Of course, we want to give them their D50 IV dextrose, and then if the IV dextrose, if you can't get your IV in, glucagon. And of course, I stated earlier that glucagon helps your body store insulin or store glucose be released into the body to help increase it, and it usually takes anywhere from 25 to 30 minutes for it to start working. So when you use glucagon, be prepared to stay there a while and go ahead and load them up, because chances are we're not going to see it jump up like we would with D50 or anything like that. Serum albumin, normal ranges for it is 3.5 to 5.2 grams per deciliter. It's a large protein found in the blood plasma. It helps maintains osmotic pressure between the vessels and the tissue, and it's used to determine liver and kidney function. Hyperalbumin, anything above 5.2 grams per deciliter. Causes for this is going to be dehydration, liver disease, impaired renal function. They're going to be the jaundice people that we see. The yellowish skin, they're going to be real tired and fatigued. They're going to have some significant weight loss if it's up like that, fever, vomiting, and diarrhea. Your urine is going to be dark, and they're going to have a gray, pasty, pale-looking stool. They're going to have pain below the right ribs and in the stomach area, and then that tenderness and all in that same area, pain and tenderness on your right side. Why is that? Where your liver's at. That liver disease. Hypoalbumin, anything low, less than 3.5 grams per deciliter. Poor nutrition, liver disease, impaired renal function, burns, lymphatic disease or cancer, congestive heart failure, and any kind of inflammatory process. Signs and symptoms, On this side, with it being low, you may not have any unless your blood albumin levels are significantly low. But if it is, you're going to have muscle weakness, fatigue, or cramps, poor appetite, and you may not be eating well to start with for it to be low. Treatments. For both hyper and hypo, albuminemia is focused on the causes. That's just pretty much it. There's nothing that we can directly fix there. Now we're going to get into our blood counts and stuff like that. Complete blood count includes red blood cells, RBCs, hematocrits, the hemoglobin, hemoglobin, HB or HGB, red blood count components are MCV, mean corpuscular volumes, MCH, mean corpuscular hemoglobin, and MCHC, mean corpuscular hemoglobin concentrations. Then your white blood cells, your differential white blood cell count, platelets, and then the other tests that go along with your CBCs are your INRs, your PTs, and your PTTs, your clotting factors and stuff like that. Normal ranges, it varies between age, gender, and the lab's testing, of course. CBCs can be affected by hydration, the time of day it is, medications, and then other blood values that relate to it. Alright, typical adult is approximately 5 liters of blood in your system. 3 liters of it is plasma. The 2 other liters of blood cells, white blood cells, leukocytes, red blood cells, erythrocytes, and platelets, thrombocytes. And these are all created in your bone marrow. Okay, red blood cells, primary purpose for these is to carry oxygen from the lungs to the body tissue and to transfer carbon dioxide from the tissue back into the lungs. The oxygen transfer occurs when hemoglobin in the red blood cells, normal basic values in adults are males 4.6 to 6.0 million of microliter. I believe is what you microliter. Females 4.2 to 5.0 million per microliter. And then pregnancy is going to be slightly lower than that for your females, and just a generalized average range for adults is going to be 4 to 5.9. Polycythemia is an increase in the number of red blood cells in your body. Causes for this, high altitudes. Why would high altitudes increase your red blood count?
Because they need more oxygen, the body needs oxygen.
Yep.
It has to compensate because it's of a low oxygen level at high altitude.
Exactly. Strenuous physical activity. People who do a lot of running. Marathoners, especially these Iron Men, stuff like that, when they start their training, their red blood count will increase to help them maintain the oxygen and circulate like they're supposed to because of the increased strenuous activity. Smoking, hydration can cause it increasing your fluid intake. Polycythemia Polycythemia vera is a slow-growing blood cancer, which can increase your blood cells. COPD, and then chronic hypoxia. Chronic hypoxia is pretty much the same reason as high altitudes. Your body is starving for oxygen, so a way to compensate is to increase the red blood cell count, which will increase the ability to carry the oxygen to the tissue and brains that needs it. Signs and symptoms for polycythemia: weakness and headaches, fatigue, lightheadedness, shortness of breath, visual disturbances, pruritus, pain in the chest, legs, chest or leg muscles, ruddy complexion, confusion, and then tenderness. All right, anemia, a decrease in red blood cells. Causes hemorrhage, destruction of the red blood cells, iron deficiency, chronic disease processes, malnutrition, perniciosis or sickle cell anemia, thalassemia. That was a good one. Chemo or radiation can kill or destroy red blood cells, and then medications like anti-infectives, some of your antibiotics and stuff like that can cause it. Signs and symptoms of having anemia: fatigue, low energy. They're going to be weak, potentially faint a lot, shortness of breath, dizziness, palpitations, pallor, chest pain with tachycardia, and hypotension, low blood pressure. Okay. Thalassemia is an inherited blood disorder characterized by less hemoglobin and fewer red blood cells in your body than normal. The hemoglobin is a substance in your blood cells that allow them to carry the oxygen, and then low hemoglobin and fewer red blood cells, the thalassemia can cause anemia, leading to your fatigue and all the other signs. Hematocrit determines the percentage of red blood cells in your plasma. And how we calculate that is you spin the blood cells down, and as the red blood cells sink to the bottom of the sample, that's how you get it. Normal values for hematocrit in adult males is 40 to 54%. Females, 37 to 46%. And then the average range for adults is generally between 37 and 54%. Pregnancy can decrease it, especially in the last trimester, as plasma volumes increase. The more need the fetus has, the plasma increases to keep volume and all up for the mother and the child. Critical values, anything less than 15% can cause cardiac failure, cause your heart to quit. Greater than 60%, they're going to start bleeding spontaneously. Nosebleeds, passing blood in the urine, stool. An increase or decrease in plasma volume affects hematocrit. Some of the conditions that can affect the plasma volume and hematocrit include your burns, overhydration or dehydration, bleeding, and or transfusions. Can all affect your plasma volume and your hematocrit. Hemoglobin is a molecule comprised of an iron-containing pigment, HEME, and a protein, globulin, so it's hemoglobin. The normal adult value is 14 to 18 grams per deciliter. Females have a normal range around 12 to 16 grams per deciliter. During pregnancy, it's going to drop to around 11 to 12 grams. Average range is 12 to 18. Critical values, anything less than 5 can cause heart failure. Anything greater than 20 can cause hemoconcentration, which will cause clotting. Just spontaneous clotting will occur in your body. White blood cells. Leukocytes classified as granulocytes or agranulocytes. Granulocytes include your neutrophils, eosinophils, and basophils. And then your agranulocytes include your lymphocytes and your monocytes. They are released from the bone marrow and are destroyed in the lymphatic system on the average of 14 to 21 days. The leukocytes fight infection through phagocytosis, and phagocytosis is the cell. What it does is it surrounds any of the foreign organisms in your system, and yep, it eats it up. It just surrounds it and destroys it. And it also helps build the antibodies in our system. When it surrounds it, attacks it, then it leaves a DNA imprint of whatever it killed and attacked in your system for your body to say, okay, we've already fought that before, so we know what to do again in the future to keep it from flaring back up. Average range for white blood cells, 4.5 to 10.8 thousand per microliter. Critical values, anything less than 500 places a patient at risk for fatal infections. Anything greater than 30,000 is indicative of a massive infection or serious disease like leukemia. Leukocytosis occurs when your white blood cells get above 10,000, and causes for that to be trauma, inflammation, acute infections, dehydration, hemo concentrations, cancer like leukemia, and medications like corticosteroids can drive up the leukocytes in your blood. Signs and symptoms of this is going to be fatigue, hemoglobinuria, hepatomegaly, abnormally large liver, splenomegaly is abnormally large spleen, bleeding, bruising, and petechiae, and these are the little small red or purplish spots that develop on the skin, and it's caused by minor blood vessels being broken, in capillary blood vessels. A lot of folks, you'll see it, it'll happen from the knees down, and old folks used to call it rust. The legs are rusted. They'll have like a tannish looking color from the knees down. That's what that is, petechiae. Leukopenia occurs when the white blood cells fall below 4,000. The causes for this: bone marrow disorders, viral infections, severe bacterial infections, cancer, medications like chemotherapy medications, antibiotics, anticonvulsants, and cardiac medicines can also cause your white blood count to drop. And signs and symptoms: headache, fatigue, fever, and bleeding. Treatments, focusing again on the underlying cause and depending on the severity: steroids, vitamins, cytokines, and any number of other substances such as interferon, interleukins, growth factors are all secreted by certain cells in the immune system, have an effect on your white blood count. Leukopenia and neutropenia. Neutropenia is the presence of abnormally few neutrophils in the blood, lead to an increased susceptibility for infection. Okay, these folks right here, some of the facilities have a protocol for these people. These people are tremendously susceptible to infections, to the point that you can't give them medications and stuff by IV. Any kind of introduction to a potential pathogen by like rectal temperatures, injections, anything like that, they have to avoid them because they're so prone to getting infections, and it can cause tremendous threats to them. White blood cell differentials, your bands, your normal values, 0 to 15%. Neutrophils or SEGs, 37 to 77. Eosinophils, 0 to 14. Basophils, 0 to 3. Lymphocytes, 10 to 60%. And then monocytes, 0 to 16%. The MCV normal ranges are in males 8 to 80 to 94, and in females 81 to 97. I'm going to run through these real quick because a lot of these tests here are not done very much at all. The normal ranges for your MCH 27 to 31. The MCHC, the normal ranges is 33 to 37 grams. Platelets, average range for those 130 to 400 microliters. They are fragments of cells that are formed in the bone marrow. They're vital for blood clotting, and they live approximately 9 to 12 days in your bloodstream. So your body is constantly producing them because they get destroyed and used up. An increased platelet count above 400,000 is thrombocytosis. Causes for this could be injury, inflammation processes, bone marrow disorders, cancer, kidney disease, acute blood loss and infection. Signs and symptoms of thrombocytosis: dizziness, headache, chest pain, weakness, neuropathic vision changes, and of course fainting. Thrombocytopenia occurs when platelet counts get below 150,000 microliters. This directly places the patient at risk for bleeding. When counts get below 20,000, it can cause spontaneous bleeding and may also cause death. Causes: impaired platelet production, mediated intravascular coagulation, using up all your platelets rapidly, immune disorders, suppression of bone marrow by chemotherapy, radiation, or any other therapy, cancer. Signs and symptoms: easy bruising, bleeding, hematuria, black or tarry stools, hemoptysis, syncope, and visual disturbances. All right, focus on underlying cause for treatment. Depending on the severity, of course, they're going to do a transfusion of platelets. Troponins are normal ranges. This is one that we always ask about. When we have these cardiac patients we carry out, first thing we want to ask, what's your troponin? Is it elevated? The normal ranges for troponin T is the one that they mainly check for here at Granville, is 0 to 0.03. Certain subtypes of troponin, the INT, are very sensitive and specific indicators for damage to the heart muscle, and they are measured in the blood to differentiate between unstable angina and myocardial infarct. Unstable angina is not going to have elevated troponin, but the MI will in people with chest pain or any other acute coronary syndromes. Okay, coagulation, your PT, your PTT, and your INR. The normal ranges for your PT is 9.4 to 13.8 seconds. The PTT is going to be 25.2 to 38.8 seconds, and then your normal range for your INR is going to be 0.84 to 1.16 seconds. Okay, in conclusion, we're done with this part. It's just having the basic understanding is going to help us understand why the hospital may want us to carry these people out and transform them. Being able to recognize the normal values and abnormal values for these patients, and also going to help us in understanding the treatment steps and help correcting this. Some other things that we got that I just wanted to kind of let you know about, where I got all my information from right here. There's a couple of papers, of course, the lab over here, and Dr. True. I sat down and talked to him. Some other things, stuff that we really don't get to understand the correlation between blood alcohol levels as far as what the hospital does and what, say, highway patrol does. So in this, I found that 100 milligrams per deciliter at Granville Health System Laboratory is comparable to a 0.10 breathalyzer test with the highway patrol. So the legal limit or being intoxicated is 0.08? Is that what it goes? Okay. So when they do a blood test over here, anything greater than 13 milligrams per deciliter is, 13 and below is going to be no exposure. They hadn't had any alcohol. So 50 to 100 milligrams per deciliter is going to be what they consider borderline as far as blood alcohol. Anything greater than 100 That's that hits that 1.0 with highway patrol. They're gonna be under the influence as far as lab values with the hospital goes. Greater than 100 or equal to 300 milligrams per deciliter, coma. So you're hitting, so if 100 milligrams per deciliter adds up to a 1.0 with highway patrol, you know, these people that we come in and we find out later that's blowing that 2.8 or that 3.4, I mean, they stand a chance of going into a coma. Anything greater than 400 milligrams per deciliter could potentially cause death. And then greater than 500 milligrams per deciliter, which would be blood alcohol, if he was capable of blowing into it, would be a 0.5, is usually fatal, leukemia. Of course, some of the other stuff that they screen for is drugs, amphetamines, barbiturates, benzodiazepines. They can screen for, of course, cannabinoids, which is marijuana, and then oxycodones. And urinalysis, all they pretty much worry about is your proteins, your nitrates, of course, your leukocytes, white blood cells, red blood cells, and they look for your color and quality. Does anybody have any questions about any of this stuff that we went over? I know it's kind of a bunch of numbers that really we don't mess with and don't fool with on a daily basis. And a lot of times, truthfully, as far as us transporting, it ain't gonna change what we do in the back of the truck. You know, we gonna haul it because they haul it. But, you know, having a basic understanding will kind of give us the understanding of why maybe potentially they being transported. That it. Thank y'all very much for listening. I sure appreciate you doing it and helping me get through this methodology class. We'll take just a break.